My name is Professor Farhat Naz. I'm working as Professor of Obstetrics and Gynaecology in Allama Iqbal Medical College and Jinnah Hospital, Lahore. I was the best graduate of my session. Up till now, I have a teaching experience of almost 19 years. I have 26 publications which have been published in many national journals. I have keen interest in high-risk pregnancy, medical education. On this academic forum, I'm going to talk about an important obstetric problem which is called postpartum hemorrhage. Postpartum hemorrhage is an obstetric emergency and every practicing physician has experienced it. It is also known as a nightmare in obstetrics. Postpartum hemorrhage is an entity of obstetric hemorrhage. We will say postpartum hemorrhage is excessive bleeding from genital tract after birth of the baby and up till the end of puerperium, that is 42 weeks after the delivery of the baby. If the amount of the bleeding is more than 500 cc after vaginal birth and 1000 cc after cesarean section, this is called postpartum hemorrhage. This definition is given by WHO. It is based on the amount of blood lost. There are many pitfalls and many questions has been raised in literature about this definition. Few pitfalls which are related with this definition of PPH is that in few patients the amount of bleeding can be more than 500 cc, but still they are hemodynamically well. This estimation of blood loss is dependent on visual inspection, and this visual inspection, it can be underestimated. This amount of blood loss does not take into account the concealed hemorrhage. Because of these reasons, this amount of blood loss after delivery and cesarean section is being questioned. Nowadays, it is appreciated that PPH should be considered if a patient is hemodynamically unstable even with less amount of blood loss, that is less than 500 cc, and this is more prevalent in our part of the world where females are suffering from iron deficiency, anemia, they are malnourished, and they are not having appropriate obstetric facilities. Depending on the duration and the time period, PPH is divided into two types, primary PPH and the secondary PPH. Primary PPH means if bleeding from genital tract is excessive within 24 hours after delivery of the baby. Secondary PPH means that excessive bleeding 24 hours after birth of the child till the end of the puerperium. Why I have selected this topic? Because this is a very significant problem specifically in our part of the world. PPH is the most common complication of third stage of the labor. This is a frequent cause of massive obstetric hemorrhage. Apart from these things, this is a leading cause of maternal mortality around the world. Obstetric audits have shown that 24 to 25% of the females, they die of obstetric hemorrhage, and PPH is the most leading cause. In this presentation, I am concentrating on the etiology, pathophysiology, treatment and prevention of primary postpartum hemorrhage. I have already mentioned that primary postpartum hemorrhage occurs immediately after the birth of the baby and within 24 hours. So in order to understand the etiology, it is important to review the physiology of the third stage of the labor. After delivery of the baby, the upper uterine segment contracts. This contraction and retraction is going to separate the placenta, which is going to fall from upper uterine to lower uterine segment. The base of the placenta, it is provided with the spiral arterioles, which are approximately 28 to 30 in number, and these spiral arterioles, they are passing through the myometrium. Once the uterus strongly contract, the uterine muscles, they behave like a living ligatures, and these contraction, they are going to constrict the blood vessels, and in this way the massive hemorrhage is prevented in the females. Always remember, after delivery, the hemostasis, it is dependent on strong contraction, retraction of upper uterine segment. It is aided with the formation of platelet plugs and clot formation. Now we are going to discuss and look into the common causes of primary postpartum hemorrhage. Regarding the etiology of postpartum hemorrhage, remember 4 T's. First T, tone of uterus. The second T means trauma to the genital tract. Third T means tissue retained in uterus, and fourth T means thrombin. The first T, that is decrease in the tone of uterus, commonly known as uterine atony, is the leading cause of postpartum hemorrhage. It contributes approximately 70 to 80% of cases. The second T stands for trauma to the genital tract, lacerations, tears, which can extend from perineum going higher up to the level of uterus. It means rupture of uterus, cervical tears, vaginal lacerations, and perineal trauma all contribute to primary postpartum hemorrhage. The third T, although lead to uterine atony, but the underlying mechanism is that either a part of the placenta has been retained, or membranes have been retained, or part of the placenta has penetrated into the myometrium in the form of morbidly adherent placenta. All these things, they lead to primary postpartum hemorrhage. Last but not the least is the low level of thromboplastins and thrombin, which lead to coagulation disorders, or is a less common cause of postpartum hemorrhage. Regarding the uterine atony can occur in few obstetric conditions, and all these conditions, they can be identified in the antenatal period. Uterine atony is associated with grand multiparity, which is pretty common in our part of the world because of the less use of contraception and our social values. Apart from that, overdistension of uterus in the form of twin pregnancy, polyhydramnios, and large baby can lead to impaired contraction of the uterus. Past history of postpartum hemorrhage, past history of retained placenta is extremely important. So it is extremely important that once we are going to see patient in antenatal clinics, all these facts, they should be explored. If our patient has these factors, then they should be marked on antenatal card as high risk patient. Apart from these things, induction of labor, operative delivery, use of medications like halothane, beta sympathomimetic agent as a tocolytic agent, and heparin can predispose to postpartum hemorrhage. Every case of antepartum hemorrhage can lead to postpartum hemorrhage. The most important thing is, always remember, is the mismanagement of third stage of labor. Management of postpartum hemorrhage. It is a common saying, prevention is better than cure. This is applicable in postpartum hemorrhage as well. The first part of management, I will describe how postpartum hemorrhage, it can be prevented in our setup. The first important thing is regular antenatal care. In antenatal clinics, we can identify the high-risk patient and can take appropriate measures during labor and in the postpartum period. In the antenatal period, we can identify the anemic patients and we can treat them accordingly. According to WHO guideline, every laboring patient should have a hemoglobin more than 10.5 or 11 gram per deciliter. Active Active management of third stage of labor is a very important factor which prevent postpartum hemorrhage. So it is the duty of the obstetrician to teach to the nurses, doctors and general practitioners and postgraduate student about the appropriate steps which I will explain just now. Apart from this, genital tract trauma should be avoided. Women should be advised not to push during the first stage of labor, and instrumental delivery should be conducted by the experienced personnel. If patient has high risk factors for postpartum hemorrhage, delivery should always be conducted in hospital where the facilities of operation theatre and blood bank is present. Related to the management of third stage of labor, the active management of third stage of labor is a national, international recommendation. Active management of labor means two steps. It is the administration of oxytocic agents and delivery of placenta with a controlled control method. Obstetric data have shown that active management of labor, it prevents postpartum hemorrhage in 30 to 40% of cases. At the delivery of anterior shoulder of the baby, 5 or 10 units of oxytocin should be administered. Previously, symptometrin was used, but because the side effects of ergometrin, now oxytocin simple, it is preferred. Once the baby has been delivered, you have to wait for the signs of placental separation. If before the emergence of these signs, you will try to deliver the placenta, it can result in inversion of uterus. The signs of placental separation are gush of fresh blood, hardening of the fundus of uterus and lengthening of the umbilical cord. Now my slides will show the proper method of controlled cord traction for delivery of placenta. One hand of obstetrician should be in the suprapubic area, which that hand will push the fundus of uterus backwards. With other hand, gentle traction is applied on the umbilical cord and placenta is delivered. Very important precaution is once the placenta has been delivered, the fetal surface of the placenta, it should be examined, the maternal surface as well. You should always ensure that no part of the placenta has been retained inside, because this retained tissue can lead not only primary as well as it can lead to secondary postpartum hemorrhage. Management of atonic PPH. The management, as I have already mentioned, that postpartum hemorrhage is a life-threatening emergency. In case of an obstetric emergency, management is not the game of a one person, it is always a teamwork. If you encounter this emergency, either in the labor ward or in the operation theatre, immediately call for help. Call your colleagues around you, call nursing staff with you, you can call the anesthetist at the same time. Basically, the management of postpartum hemorrhage is a teamwork. Apart from these people, hematologists, porters and blood bank services is a part of team as well. In the management of postpartum hemorrhage, resuscitation and specific management is going side by side. So in the case of ongoing postpartum hemorrhage, two teams are working simultaneously, as the management of PPH consists of resuscitative measures and specific measures to control the cause of the bleeding. The resuscitative team is going to look for the vital signs of the patient. They are going to make assessment about the amount of the blood loss and its impact on the pulse, blood pressure, output and other thing. Whenever there is a postpartum hemorrhage, immediately secure at least 2 IV line of the patient with 14 gauge granula. Usually in the labor wards, this number of Brenla is not present. So I will request everybody that make PPH management packs and in which 14 gauge Brenlas should be present. Blood should be taken and should be sent for investigations. If blood is not available, this is the situation in our setup. In cases of unexpected postpartum hemorrhage, immediately start with fluid resuscitation. You start with crystalloid, and if blood has not been arranged, colloid infusions, it can be used. Whatever the amount of fluid and blood products are used, it need to be documented by a staff on a paper. And once the situation has been controlled, then the monitoring of the patient, it is very important. If facilities of CVP is present, this is extremely good. But I do understand that CVP monitoring in cases of PPH needs experienced anesthetist, and it is usually available in tertiary care hospitals. Apart from correction of hypovolemia, the specific treatment of postpartum hemorrhage in cases of uterine atony include these steps. Number 1, you have to put your hand on fundus of the uterus and feel whether the uterus is palpable or not. In cases of uterine atony, the uterus is full of blood and clot, and in majority of the cases, uterus is not palpable. Immediately rub up the fundus of the uterus. It will initiate a uterine contraction. This is the time period once the obstetrician is calling for help. Apart from uterine massage, you can do the bimanual compression of the uterus, which is depicted on the picture in front of you. One hand should be placed at back of the uterus, and other hand in the form of a fist should be placed in the anterior fornix, and uterus should be compressed between two hands. It is a very effective measure, and it has saved the life of the patient in multiple times. When these two maneuvers are being done, that is the rubbing the contraction of the uterus and bimanual compression, oxytocic agents, they are given by the resuscitation team. It can be oxytocin infusion, ergometrine, and in extreme cases, prostaglandins can be used. It is very important that while dealing with the case of atonic PPH, you should be sure that the uterus is empty and the placenta has been completely delivered. If there is any doubt that the part of the placenta has been retained and patient is bleeding, then kindly shift the patient to the operation theatre and under anesthesia explore the uterus. If blood bleeding is still continued and you are thinking about the operative intervention to control PPH, you should try uterine balloon tamponade. Uterine balloon tamponade, it is taken as a tamponade test. This is an intervention which is between the medical and the surgical treatment of postpartum hemorrhage. In this context, Beckery balloon, it is used in Western countries. It is now available in Pakistan, but the cost of the Beckery balloon, it is 40,000, and it seems it is difficult to be used in our setup. A very nice, cost-effective, highly effective alternate of Beckery balloon has been used in South Asian countries, and this is in the form of condom catheter condom balloon tamponade. This is a very simple thing, a device. It was invented basically in Bangladesh and it is used very effectively. It is almost as effective as Beckery balloon. My two slides are just showing that how this device is going to be prepared and it is going to be used. If oxytocic agent, bimanual compression, balloon tamponade has not worked, then last resort to treat this problem is surgical intervention to treat primary postpartum hemorrhage. In surgical intervention, the thing which has emerged as a breakthrough in the last decade is different form of brace suture. B-Lynch suture is very effective to control atony of uterus. It was devised by Mr. B. Lynch in year 1998, and soon after the publication in British Journal of OB/GY, it emerged, it spread all over the world. Afterwards, a lot of uterine brace sutures have emerged. Heyman suture, classical suture, and so many things. They have emerged and being used by obstetricians all over the world. The overall success rate of these brace sutures, it is 70 to 80%. All the postgraduate students, the general practitioners who are performing cesarean sections, they should learn these brace stitches. Apart from brace stitches, other thing which can control the postpartum hemorrhage due to uterine atony is stepwise devascularization of uterus. This is a specialized procedures in which the uterine arteries are tied at various levels, and tying of these uterine artery is going to reduce the blood supply and it is going to control the ongoing hemorrhage. If brace sutures, stepwise devascularization does not work, then the options are internal artery ligation and peripartum hysterectomy. These decisions should be taken by the consultant obstetrician. Practically speaking, internal artery ligation needs a lot of skills, and peripartum hysterectomy is means end of the reproduction career of a female. But sometime in life you have to decide between uterus and you have to decide between life, then you have to resort to hysterectomy. Once operative intervention is over, patient need an appropriate post-operative care, because postpartum hemorrhage is accompanied with multiple transfusions. A lot of complication can emerge as a result of this obstetric emergency. The list of complication is depicted on the slide. In the end, I will simply say anticipation, early detection, appropriate management of postpartum hemorrhage can save the life of a female. And the management start with very simple measures: identification of high-risk patients, appropriate management of simple labor, and incorporation of expert people to manage PPH always bring a fruitful result. Thank you.